Hi everyone, my name is Ines from the MD 2027 cohort. Today we'll be going over the second portion of Lab 3, the upper respiratory tract. More specifically, now we'll go over the pharynx and the larynx. So just a few things to straighten out before the lab content. This area of the body might seem to have convoluted innervation, and I only say seem because the same way you can remember plenty of different highways and the different streets they branch into, you can also navigate this pretty well. So here's a small overview of the relevant cranial nerves we'll also brush up on, and you can also refer back to these once we're done the video. And so we'll start off with CN9, which is the glossopharyngeal nerve, CN10, the vagus nerve. The more specific branches of the vagus nerve that we'll cover are the superior laryngeal, and that one has two branches, the external branch and the internal branch. And also we'll be covering the inferior laryngeal, which is also known as the recurrent laryngeal. Hope the video is useful to you guys, and without further ado, let's get into the video. Typically with a larynx specimen like this one, the first thing to do is kind of have the right orientation. So I try to find the bulging convex cartilage by sight, and if that isn't obvious, then try to feel for the pointy cartilage that kind of pokes out a bit. And that's going to be the thyroid cartilage. With that, we know then that that is the anterior side of the larynx. Locating the superior end is done by feeling for the ring-like hyoid bone, which is a key landmark, and here we know it as C3 level of the spine. Going inferiorly, we cross again the thick and wide thyroid cartilage around C4 level, and that's followed by a space, and then the last component, which is the cricoid cartilage at C6 level. Under this structure, we'd have the trachea and the lower respiratory tree, which will be covered in the following video. And we can see the trachea rings as we move a bit more posteriorly on this specimen. Okay, so we've covered the external portion of the larynx. Now we have to figure out what's inside. We first start off with the epiglottis. The cartilaginous structure is responsible for closing the larynx off, like when you swallow, so that nothing goes down into the lungs instead of the esophagus. Specifically, small muscles are involved in this closure, which we'll discuss a bit later on. The mucosal surface here is the vestibule. Because it is called epiglottis, it must be superior to the glottis, naturally. This is the glottis right here, which is the area known as the true vocal cords plus the space in between them, also known as the rima glottitis. The false cords are actually just folds of the vestibule right above this. Between these folds, we have a concave space that we conveniently call the ventricles. Below the true vocal cords, or the glottis, we have the infraglottic space. So if we remember correctly, around here should be C6, meaning the vocal cords are around C4 to C5. You might also be asking yourself, why the emphasis on spinal levels? How is that medically relevant? Well, first, it allows us to orient ourselves on imagery that doesn't really show softer tissues that well. For example, if there's something abnormal at around C4 level on a radiograph, we know that this could involve the thyroid cartilage, and by extension, it could be putting the vocal cords as well as important neurovasculature in that area at risk. We also need to know the spinal levels for some urgent procedures like tracheostomies, just so we know not to potentially damage any important structures in that area once again. So superiorly on this posterior view of the larynx, we can see the connection between the epiglottis and the tongue. The lingual tonsil will be located right at the base of the tongue. And just below that, when we bend the epiglottis a bit downwards, we have the two lateral glossoepiglottic folds and one median glossoepiglottic fold. The small valleys that are kind of formed between these two folds are known as the valleculae. If we were to close the larynx and go a bit further down, we'll find two spaces on each side, known as the piriform recesses. And so these spaces are known locations where pills and fish bones can get stuck. Even after you close off the larynx and you swallow, it can accumulate debris in those two lateral pockets. The landmarks we mentioned earlier also are going to indicate the transition from one structure to another and the changes in name. So at C3, we have the end of the oropharynx and its respective division into the larynx and laryngopharynx. This is also going to be the widest level of the pharynx. At C6, we have the transition from the larynx to the trachea and the transition of the laryngopharynx to the esophagus. And we can also notice and point out that this is the narrowest point in the whole pharynx, as we can see here. So let's break down the pharynx and focus on each part separately. For the nasopharynx, we covered it in the part 1 video, so we'll move on straight to the oropharynx. In the oropharynx, the glossopharyngeal nerve, or CN9, is the main player for sensation. It's going to range from the soft palate to the base of the tongue, and it also contains the palatine tonsil, which, if we look over here, will be in between the palatoglossal fold and the palatopharyngeal arch. Finally, in the larynx and hypopharynx, the vagus nerve is responsible for the sensory and motor innervation. So these both start at C3. So this helps us understand why the gag reflex and the cough reflex have different innervation. Although they're both protective, they are going to protect different things. The gag reflex starts at the oropharynx with sensation. Think of something expired that you don't notice initially when you consume it. It doesn't want whatever in that area to be swallowed and go down the pharynx. So for the sensation portion of the gag reflex, it is done through the CN9. The efferent or motor component is going to be controlled by the vagus nerve on the other hand. Now for the cough reflex, it involves protecting the larynx and your respiratory tree. So it tries to get something out of there once it already enters. Both the afferent and efferent, so sensation and motor, are going to be controlled by the vagus nerve, as it is the nerve that is controlling this area. So let's take this layer of muscle and connective tissue off to better visualize the action of the smaller muscles on the vocal cords. Here we have the cartilage base of the larynx. The intrinsic muscles are easier to remember if you know which cartilage is under them. So if we take a look posteriorly, stacked above the cricoid cartilage, we have the arytenoid cartilage. When it's covered with a mucosa, this forms a fold that connects the arytenoid cartilage and the epiglottis, and that's specifically called the aryepiglottic fold. And so it would be located in this area, and we can see on the actual specimen how this fold is made. Anteriorly, we recognize the big thyroid cartilage. Above, it's bound to the hyoid bone by the thyrohyoid membrane, and below, it's connected to the cricoid through the cricothyroid membrane. These membranes are important because they allow the passages of the branches from the vagus nerve that innervate the small muscles in the larynx. The internal branch of the superior laryngeal dives through the thyrohyoid membrane, and it's going to provide the sensation above the vocal cords. The sensation below the vocal cords is going to be controlled by the recurrent laryngeal. The recurrent laryngeal is also going to innervate all the muscles in the larynx except for one. The cricothyroid muscle, which is going to be found anteriorly, is the only one that's going to be innervated by the external branch of the superior laryngeal. Its function is to stretch the vocal cords longitudinally, so it's kind of like tuning a guitar so you can change the pitch of the voice. The posterocricoarytenoid is the only muscle that's going to abduct and adduct the vocal cords. It's controlled by the recurrent laryngeal. So when you sing, the rima glottitis is going to be closed, and sound is going to be produced through the vibration of the cords. The posterocricoarytenoid is going to be contracted in this state. When you need to breathe in, the vocal cords are going to need to be open, and that's going to allow air to go through. In this case, the cricoarytenoid is going to be relaxed. One key thing to note is that the recurrent laryngeal is called recurrent because it's going to loop around a vessel and then come back to the larynx. So it goes down and then comes back up. On the right and left sides, however, the vessels it loops around are different. On the right side, it's going to loop under the brachiocephalic artery, whereas on the left side, it's going to keep going a bit more and then loop around the aortic arch. In terms of the blood supply for this area, the superior thyroid artery and the inferior thyroid artery, as well as the venous equivalents for these, are going to be responsible for draining.